Who does PCNL? Okay, keep your hands up if you guys do PCNL. Who does PCNL? Okay, keep your hands up. Who does every case go perfectly, never have bleeding that obscures your vision, never lose access, never get septic and have to abort or anything like that? Exactly. So that's like what today's talk is about. So I have financial disclosures that are not relevant. So I'm going to touch on a little bit today about how my thinking of indications for PCNL have changed over time. We'll talk a little bit about the complications that might send your case off the rails, so to speak. And my way of kind of approaching these cases to try to minimize the chances or risk of that happening. We'll touch on a little bit about TXA and its potential role and antibiotic usage, and then we'll finish up with several cases that kind of illustrate these points. Okay, 1.6 centimeter lower pole stone, moderately dense. Who's doing shockwave? No? Well, educated group of people here. Who's doing ureteroscopy? Okay, couple ureteroscopy. Who's doing PCNL? Ureteroscopy? Oh. Yeah, so it sounds like most are doing ureteroscopy for stone like that. What does the guidelines say? Granted, they came out like when Brexit happened, but anything over 2 centimeters, PCNL. If it's less than 2 centimeters and not in the lower pole, you certainly can do, kind of whatever you want. If it's greater than 1 centimeter in the lower pole, it only says you shouldn't do shockwave. So it leaves this big gap, this like 1 to 2 centimeter kind of ambiguity there. And actually, if you look at the EAU guidelines, which is like 6 years later, it's pretty much the same. You have this kind of ambiguity between 1 to 2 centimeters. Manoj Mongo, who gives a nice talk on grand rounds in urology, plug for Manoj, he kind of narrows down that gray zone. He says, for me, if the stone's bigger than 1.5 centimeters, I'm managing it percutaneously. If the stone is less than 1.5 centimeters, he's generally doing ureteroscopy and or S-wall. But what about mini PCNL? Manoj doesn't like mini PCNL, I think. I want to speak for him, but I think he would agree. But, I've talked about mini PCNL at this conference. I don't have there we go. This is ultra mini over here, a mini here, and a standard, or as Manoj would say, maxi over here. So for me, mini PCNL, and I've presented this before, plays a role. And it's really changed my way of thinking about how I approach these stones. So if I have that kind of what I will call a fairly frustrating lower pole ureteroscopy that's going to take some time and be at an angle and I'm not going to be able to relocate it, I'm probably going to approach that with a mini. And if I have a smaller big stone, I'm probably going to approach that with a mini. And it goes great. Like if we have this 1.4 centimeter mini stone, it takes an hour, patient's stone free. It's got to compete with ureteroscopy. So they got to go home with a stent on a string and it's got to compete, right? But sometimes it doesn't go well, all right? Sometimes you're cruising along and then something happens, the next thing you know, the case is off the rails. And so today is not about me showing you how to do complex PCNLs or give you tips for that. Today is not about me showing you my most complex cases and look how I get through these things. Today is about how to just keep the train on the tracks. And for what I say about coming off the tracks, what I mean is sepsis, having to stop the procedure. Maybe you got a bunch of fluid in the chest and anesthesia is communicating with you. This was actually at 2 in the morning. But if you have bleeding that obscures your vision or clots that obscure the stones, losing access, injuring the collecting system in some way and having to abort, or just, God forbid, this ever happened to you, but something like, viscous injury. So I really break it down into 3 main principles in my mind. Careful preoperative preparation, a very systematic approach intraoperatively, and then a thoughtful exit strategy. So that's like the big picture, and we can go into that in some detail. In terms of preoperative preparation, it starts with imaging review at detail. And the residents know that I really agonize over the preoperative imaging because you can pick up a lot there. This is a patient with a 3 centimeter lower pole stone, can't see it. She's 100 pounds soaking wet. Now, if I do prone PCNL, which I do, there's other in the audience who do supine, but if you do prone, I'm going to image them prone because I want to know what it looks like in the OR. I'm not going to repeat the scan if they haven't, but if I can order it, I will. But this is like my window. That's the one posterior calyx I have here. That's going to be a bit of a challenge. Ultrasound would help here for sure. And I'll tell you, if I go a click down, it's her iliac crest. If I go a click up, it's more liver. So what about where's the pleura? These things are really important to look at. Where's the colon? Choose the right operation for the right patient. I know it seems really obvious, but you have to stick to that. So if you have a 3-centimeter stone, if PCNL is not in your wheelhouse, refer it. The patient's going to do better, and honestly, you'll probably get bothered less with patients bouncing back to the ER from Steinstrasser or something else like that. Patient on the right had a poorly functioning kidney, so that kidney obviously came out. Patient on the left had a very well-functioning kidney, and so that patient had a multi-access complex PCNL. So I'm not going to do a mini on that patient on the left, and I'm certainly not the patient we talked about earlier. I'm not going to stick a standard size sheath in a 1.6 centimeter lower pulse stone. So I think you just have to choose the right operation for the patient. Preoperative urinalysis is what's mandatory in the guidelines, but culture I think is really important too. Best practice statement for the non-complicated patient is listed here. If you ask endourologists how many of them follow this particular recipe, it's about half, and that's of endourologists. Nobody uses flagell. So these are obviously the AUA best practice statements, but a lot of people aren't following them. I would say my OR looks a lot like this. The residents would tell you I'm not the most responsible steward of antibiotics. But these are 2 randomized controlled trials that looked at positive cultures or high-risk patients, and you see they're mixed. One found there was a benefit for a week of treatment, one found maybe just 2 days. I think at least 2 days would be what's safe. In terms of the most important part of the preoperative preparation, it's the equipment and the planning. You have to think, am I doing this supine? Am I doing this prone? Do I have my fluoroscopy ready? For me, I use a handheld ultrasound. Is it charged? Sometimes it's not, and that's going to be frustrating. Do you have backup for all your stuff? Like when the lithotripter stops working, do you have another one? When the scope falls on the ground and gets contaminated, do you have another one? So plan with your coordinator in the OR and make sure you pretty much have everything you need. What if you can't dilate? You need a fascial incising needle. Does your hospital have one? So having all these things around, do you have a K tamponade balloon if you need it? Just making sure you have everything you need and thinking about all that before you start. But when you start, you really want to think about how you want to approach the patient. Is there a stoma present? Do I need access to that? Supine sounds pretty good for that. Do I have this patient who's an extremely contracted patient? That's the most he moves, period. Am I going to be able to get that patient supine? What if I need an upper pole access? Do I want to do supine or prone? Do I need access to the urethra? Also, am I going to do a prone ureteroscopy because it's a little on the bubble? Maybe it's that 1.6 centimeter stone and I'm going to generate a lot of debris, and maybe I want to drop a mini sheath in at the end just to evacuate out the fragments. So maybe I'll do prone ureteroscopy and just drop in a sheath at the end. So just think about how you want to do the case and be flexible with your approach. This is something I'm big on. The residents know that. I have tube managers set out. There's a lot of cords and tubes and fibers, and like your second grade teacher told you, if you've got cluttered space, you've got cluttered thinking. So make sure you've got everything organized the way you want it. Let's see. Oh, something. Wow, that really went. Choose the best calyx for the case. If it's safe, sometimes if it's not safe. Sometimes the patients need to get done what they need to get done, and you have to counsel the patient. They may have a pulmonary complication or something. But choose the right calyx and make the perfect puncture, which for me means down the axis of the infundibulum, right in the papilla. Your bleeding risk is going to be a lot less. And I can do that a lot better with ureteroscopic guidance because I can see where my needle comes in at the right trajectory. And we'll talk about an illustrative case. And then this is all the middle of the case, right? Try to avoid all the pitfalls. Don't kink your wire. That could be a terminal event if it's a bad kink. Don't blow up the balloon without the access sheath on it, because now you got to let down the balloon, and now you got a bunch of bleeding in the collecting system, clot everywhere, you can't find your stones. Don't torque too much, right? If you're torquing that much, maybe you need to go to a flexible scope, or maybe you need to drop another access. So all these kind of things to think about and try to avoid, and try not to lose access. Sometimes that's also kind of a terminal event. Through and through wires can be really helpful for that. TXA, that's something that I've kind of brought into my practice a lot more. There are data that would suggest that this can be quite useful. A Cochrane review found decreased risk of transfusions, complications. Another randomized controlled trial found that there's better visualization, which is probably driving that better stone-free rate. And I will say subjectively, it does look a little bit better. David Hinojosa, one of our residents, did a review, a Bayesian network analysis review with Brian Eisner, and they found that perhaps putting TXA into the irrigant fluid may actually be better than systemic TXA. I haven't tried that. So also stealing from Manoj, this is a schematic that he uses that I have altered. Because I use two cysto towers, two monitors. The main reason for that is we do a lot of combined intrarenal surgery. So that means, and sometimes simultaneously, especially in the minis, I'll use a split screen, and I may be working down below doing ureteroscopy, and the residents, up top doing the percutaneous portion of the procedure. And this is our split leg table. So this is our AUA core curriculum video, and if it looks familiar, you'll see we're prone, so air marks posterior. And this is the beauty of ureteroscopy. I can kind of see right down the infundibulum. I understand my trajectory. That's a long upper pole infundibulum. That's going to be, even though that's renal pelvic stone, I may not have great access to that from the upper pole. I probably need to find an interpolar calyx, which we did. Here's some air, it's posterior interpolar calyx, and I can aim right at my ureteroscope tip fluoroscopically, and I can get a perfect papillary puncture, right? Bloodless puncture, even though it's a small calyx. And then this is I'm trying to get my, I don't know if I can scroll here forward, but this is a technique that we, described in this video, trying to get there, eventually. Can't tell if that's happening. Okay, and so, we pass the wire retrograde from the scope right out the needle because we're all lined up ureteroscopically. And so that can give us through and through access really quickly without baskets and things like that. So you can see how we just, pull it out the flank, and it's a nice little way of doing it. Exit strategy. I don't leave nephrostomy tubes. This is Eileen Bogeltai. She's a pediatric urologist now at Hackensack. But that is the first case I didn't leave a tube, and I kind of never looked back, and that was many years ago. I will say maybe once a year or something, I'll leave a tube, and it may be because of some anatomic concern, a neurogenic patient, or social concern, or something like that. But for me, to leave a tube in, I got to answer these questions. Yes, I need to re-enter this kidney. I can do more through this current access, and I'm far away from the diaphragm. And I would say it's really rare that the answer to all three of those questions is yes. So I don't leave a tube. I notice bleeding is not on there because I don't think the tube does anything to decrease your bleeding risk. Stent. I leave a stent on a string. That's my method, especially because sometimes I'm competing with ureteroscopy. But if you ask yourself this one question, if I get called at 2 a.m. that the patient pulled the stent out, am I going to feel compelled to bring the patient back to the ER and stent them? Are they that high risk? If the answer to that question is yes, don't leave the string on. And if the answer is no, leave the string on. My fellowship director there, when we got a couple hours into a PCNL, used to just kind of play this in the background. You got to know when to hold up, know when to fold up, know when to walk away, and know when to And so that would start playing, and it kind of trained me, it's like a dog. I was like, okay, this is the point in the case where we are having diminishing returns and maybe we're doing more harm than good. And sometimes you just need to know when to hold them and know when to fold them and come back for some other procedures. So thanks, Rick. So we don't need to listen again. So this is just a series of cases I'll try to buzz through real quickly. This is a patient with a calyceal diverticulum from a fairly large infundibular stone. And what I want to show you here is that this is the 12th rib. Actually, you'll see it come off. And this is the 11th rib. I mean, if I'm supracostal here, I'm in the chest. Notice this is prone. So this is like, the anatomy I'm going to see in the OR. So when I bring him to the OR, and I see the stones above 12, and he's prone, it's like, ooh, there's my calyx. I don't think I'm accessing that calyx. And I don't really think I can get to that stone from any other calyx percutaneously. So I got to be flexible. So I'm going to change. I'm going to do a prone ureteroscopy. But no, I'm not, because, surprise, he had a ureteral stricture. So I couldn't get through. So am I going to balloon dilate it? Am I going to do something aggressive? Am I going to perk some non-ideal calyx and torque like crazy and bleed? No. I'm going to know when to hold them and know when to fold them, put a stent up, and bring him back. So I got the scope up this time, but I brought him back prone, even though I knew I was going to do him ureteroscopically, because if I generated a bunch of debris, I can drop an access into some more ideal calyx and just suck it out with my lithotripter and get the guy, stone free. And that's what we did, nice and safe. Get the perfect puncture. So this patient came to me, fairly large stone burden, but already been accessed for a septic episode. So you're like, I'm going to dilate this access. It's upper pole, perfect. But when you shoot the retrograde, anyone happy about the trajectory of that access? If you dilate that up and you start torquing that, I mean, it's not going to be great. So I know it's easy, but don't take shortcuts. So we put a ureteroscope up there, and I swear this is literally the same papilla I wish I had to see the picture. It's the same papilla, but it's a completely different angle. And so we clean this guy out really well. He has a bunch of third-degree burns, by the way. But this is the nephrostomy tube, the IR nephrostomy tube, and this is my access. I mean, this is the same papilla entering in the same place in the kidney, but look how far apart they are on the flank. So this is, something to keep in mind. So in terms of imaging review, I think it's really important to look at all the complexities. What you're seeing here, dilated upper pole, is the only place in this kidney that doesn't have stone. So she's a really complex stone system. And if you go down, I start getting the iliac crest. So I can't really access anywhere but the upper pole. But before I could, she came in septic, and IR placed a nephroureteral tube in an outside hospital closer to home for her. So we had this access, and when we came to the OR, but oops, I didn't notice she actually has a bifid system. And this is a really complex lower pole, staghorn calculus, but she did have some stone up here in the upper pole, in this complex system here. So I tried to dilate it up. And tried to work with it. Didn't go that well. So I'm like, okay, I'll put the ureteroscope up and go try to find another access. And in the process of doing, that, here's my retrograde wire. Now I'm going to put the ureteroscope up. I perforated through an infundibulum with a dilator that went too high. Now I got a lot of stone to do. Do I push through and extravasate everywhere and cause a urinoma, or do I know when to hold them and know when to fold them? And so we got out, put the PCNU back in, and then came back to fight another day. In this case, I managed the upper pole system this time with a mini, just to minimize her morbidity, and then found a very lateral calyx, which I wouldn't normally access, but I had no other choice given her anatomy, and we were able to clean her out with a second access. So even though we had an injury, it could have been worse. And so, do it safely. And just to put it all together, this is a patient with a pretty, I would say good-sized stone burden. What I want to show you that's coming up here is the colon, sneaking up mid-pole, and then not a lot of space here to the lower pole. But what I want to also show you is she's got a conduit on the other side. So what are you going to do? Is IR going to access this for you? Are you going to access this by ultrasound? You got to think about that as you're planning. I always prefer to access if I can, because of reasons like you saw in the other case. So I like to bring these patients to my office on the VUDS table where I have fluoro, and I scope them, and I see if I could see the UO. And if I can, I put a wire up it. And if I can, I stent them. That's actually stone, it's not a retrograde. So that way when I bring them to the OR, I just externalize the stent and she is in flank, so I can have access to both. Maybe Matt would have her supine, but I'm a little nervous about the lower pole and I don't love supine access for upper pole. So I put her in flank and we externalize. We have a through, we're about to get a through and through wire when I put my ureteroscope up, access directly on it, so I'm not torquing, and we clean her out. So that's kind of like, how you can just sort of put it all together, be very flexible and adaptable and thoughtful about your process. So just to stay within time, I'll say the main things are really careful preoperative preparation, consider TXA as an adjunct, it may be useful, and get the perfect puncture, avoid the pitfalls, and remember my fellowship director playing in your head. Sometimes you got to know when to hold them and know when to fold them. Thank you.